So the topic is called Fascia Research Update, connective tissue research related to interoception, proprioception, and sympathetic fascia innervation. And let me start by looking at a new calculation on the number of sensory nerve endings that we have in the human body in the fascial tissues. This is a publication that has been done by a scientist at the University of Leipzig. His name is Professor Martin Grunwald, and he has published it in the form of a lengthy footnote where he shares the way how he calculates it. And he is known as one of the world leaders on haptic perception. And he had done a similar calculation before on how many nerve endings are in the human skin. And he came up to an incredible number of about 100 million sensory nerve endings. And based on two-dimensional density counts, this one is from Professor Menz's laboratory on the upper right here. So that's a cross-section through the thoracolumbar fascia, and that's about an area of 2 millimeters by 3.5 millimeters. And in dark brown, you don't see blood vessels. These are sensory nerves. And of course, you cannot see how many of them terminate in this section. So you would need different staining for that, but they don't look as beautiful. But you can use these two-dimensional staining sections and then do a three-dimensional calculation based of the total body volume, three-dimensional volume of fascial tissues in the human body. And he used the definition of proper fascia according to the Terminologia Anatomica, in which only dense collagenous connective tissues that you would call proper fascia are included. And then he calculated that for the complete human body, and he came up to the number of about 100 million sensory nerve endings. And that makes it really plausible to talk about fascia as a sensory organ. When we came up with that formulation maybe 6 years ago, my scientific colleague, they raised some eyebrows. Just because we found a few nerve endings in fascia doesn't make it a sensory organ. And they thought, oh, Robert, you are very enthusiastic about your fascia, but I think you are overdoing it there. But if you have such a richness of many million sensory nerve endings in fascia, then you can actually, without stuttering and without parentheses, talk about a sensory organ in terms of the complexity. However, when we looked at the way at which he had counted, we realized that he had done the calculation based on the most restrictive terminology related to fascia, which is the Terminologia Anatomica. And in this terminology, it is the most restricted, but also the most precise. Even an aponeurosis is not included. So the part of the lumbar dorsal fascia, which is a continuation of the latissimus dorsi, would not be included because that's parallel fiber. And in the Terminologia Anatomica, only so-called irregular, or you would say multidirectional, dense pieces of fascia that you can cut with the scalpel without the use of a microscope are included as proper fascia. So according to that terminology, there is no superficial fascia. So the subcutaneous connective tissue that Carlos Stecco calls superficial fascia, at least one layer within it, they are very, very clear in the latest issue of the Terminologia Anatomica. There is no superficial fascia, though they even recommended not to talk about camper fascia. And that was very weird. It was very logical if you read their reasoning behind it. They were very much stressed by the disparity of people talking about very different kinds of tissues or connective tissue as fascia. So they really did an effort to bring in some clarity. However, that very logical, very precise terminology contradicted to the common usage of terms like camper fascia and superficial fascia in such a way that many anatomy books did not follow that book. So, of course, as you know, every author has his personal application, what fascia is. For some, bones are included. For Gimberto, any fibrillar network that exists in the human body, even if it's inside of a muscle cell, is part of fascia. And then, of course, fascia has not much anymore to do with connective tissue, and you're free to use the term fascia as you want to do it. But as part of the Fascia Nomenclature Committee, where we had a 4-year, very deliberate Delphi process where we tried to come to one agreement and we failed, we came up finally with 2 recommendations, which are not restrictive, but they are recommendations. And in addition to the histological definition of aphasia, which is pretty much synonymous with the terminologia anatomica on which Martin Grunwald had based his calculation, we came up with a more functional definition of what we describe as the fascial system. And that fascial system is part of the connective tissues. And these are these connective tissues which are part of a tensional body-wide force transmission system, whether it is a joint capsule, whether it's the intramuscular connective tissue, the endomysium and the perimysium, which are not part of aphasia as defined of terminologia anatomica, but so the intramuscular connective tissue that you cannot cut with a scalpel without a microscope, they are now included because they are part of a body-wide force transmission system. So, of course, many of you know that new definition. I highly recommend it because it has been the outcome of a 4-year-long Delphi process among the experts, and it is very clearly defined which tissues are then included. And then you don't need to fight whether the tough connective tissue on the bottom of the foot, whether you call that plantar fascia, plantar aponeurosis, or plantar ligament, because in this functional definition, these are all regional specialization of a body-wide functional system for tensional force transmission system. So that is the background why then Carla-Steckerow and I, based on this functional definition of fascia, we came back to Martin Grunwald and asked him to restart his elaborate calculation again. And then to look at how, so if we then include the subcutaneous connective tissue, so the soft fascia, and if we then include the visceral connective tissue, you come up to an average body mass of about 12.5 kilograms in an average adult human body, which is about 70%. You read all kinds of different calculations, how much of the body mass is made out of fascia, depending on whose terminology you use. But if you use the functional definition that we had recommended of the fascial net, then it is about 17% of the complete body mass. And that, of course, ranges from one person to the other, but that would be the average. And then you can do the calculation again, and you come up to 2.5 times a higher number than the calculation that Martin Grunwald had done before. And then we just published this in David Lessenduck's chapter. So if you want to have a reference for our new statement, this would be the best reference, the chapter by Carla and me in David Lessenduck's books on fascia as a sensory organ. And a similar chapter is also coming up in a special chapter, more extensive, in the second edition of Fascia in Sport and Movement. And based on that calculation from Carla-Steckerow, Martin Grunwald, and myself, in which we really made it transparent how we did the calculation, we came up to the number of about 250 million nerve endings. And you may say, who cares whether it's 100 millions or 200? It is a lot. And but it makes a difference in retrospect because then it is out of question that the fascial net is our richest sensory organ altogether. It is richer than the skin, it is richer than our sense of seeing, from whom most people have assumed that for us Homo sapiens, the sense of seeing is our most dominant, our richest sense in terms of specialization. Of course, only if you see. It may be different in a dog. The dog, if he experiences you and your surroundings, their primary sense seems to be smelling. And then the vision and the colors come in secondarily. But that was the basic assumption that if we are seeing Homo sapiens, it may change if you are blind, then this is our richest sense, and then the other senses, including proprioception, are overridden and they are enslaved by the sense of seeing. So we have to rewrite neurophysiology that the body-wide fascial net, if you use fascial net according to that definition, of the functional definition, is by far our richest sensory organ. And then, of course, you want to know sensory perception for what? So for what perceptions? So for what stimulations? And one area that Carlos Decker also touched is nociception, whether fascia can be involved and can be a generator for soft tissue pain. Soft tissue pain means neck pain, shoulder pain, and of course low back pain. But one of the areas of soft tissue pain that has most specific research behind it, because of its dominant role in sports medicine, is delayed onset muscle soreness. That is the soreness that you have in your muscular tissues uh, after you do particularly downhill running, eccentric loading. And the classical theory many years ago was this is the lactic acid, because after intensive exercise, you do have that very high acidity, and the acidity would be a plausible explanation for stimulating in a nociceptive manner the free nerve endings in your muscles. So that was a beautiful theory, but there was a little ugly fact, which was the timing. It was a wonderful theory, but the timing didn't fit because the lactic acid already after 1 hour is back to normal, but the peak of your delayed onset muscle soreness is 1 or 2 days afterwards. So now the prevalent theory in sports medicine is the primary injury. Most people think it is in some muscle fibers, particularly in the set discs, but that is questionable because they found these micro tearing injuries inside of the muscle fibers only with electrical stimulation, not yet with voluntary stimulation. So it is so, but most people assume there is some micro injury while you do the downhill running, but the injury is not what hurts you. It is the repair process in which you have inflammation and subsequently microedema. So, as part of the wound healing, you have an increase of water, and that's called edema in the area of the injury. And then the timing makes sense because then the increase of the local water pressure is 1 or 2 days later. So the pain you have is not the injury, according to that explanation. The pain you have is due to the repair process, to the increased water pressure, which is then mechanical pressure on the free nerve endings in the area. So that is the current state of the explanation. But the big question are, where are the original injuries? Are they in fascial elements or in muscle fibers? And there have been a number of very elegant investigations stimulated by the new focus on fascial tissues also in sports medicine. So they took some people who had been lowering a barbell with their right arm and lifting the same barbell with the left one. Then if you do that a few hundred times, the biceps on the right arm develops delayed onset muscle soreness 1 day later, and the left one only is tired. And the next time you have delayed onset muscle soreness, I want you to ask the question, where is the origin of the pain? Is it in the skin? Is it in the bone? Is it in the subcutaneous fatty connective tissue? Is it in the muscle? In which muscle? Or is it in the fascial envelope around the muscle? Nobody really asked that question, according to my knowledge, before, but that was the question that they had in these Danish studies here. So on the arm that had the delayed onset muscle soreness, they did stimulation, either electrical stimulation, that was the study where they did the electrical stimulation. Before they had done it with needle stimulation and with hypotonic saline injection. And you do it at such a low degree that there is a minute stimulation, so a very low electrical current or a low amount of hypotonic saline injection. And then you ask the client, is this painful? And when they did that on the left arm, that was only tired but didn't have the delayed onset muscle soreness, none of the tissues had a very sensitive nociceptive response. But on the right arm, they had a nociceptive response, not from the skin, not from the subcutaneous connective tissue, not from the muscle belly, but from the fascial envelope, very, very clearly. So when you stimulated the fascial envelope, the clients would say, oh, it hurts, but only on the right arm. And when you do the same amount of stimulation in the muscle fibers, it's almost nothing compared with the other arm. And very elegantly here, they did that not only with the biceps brachii, but also with the brachialis muscle, which is also an elbow flexor underneath. So next time you have delayed onset muscle soreness, you should discuss, maybe in a humorous manner, whether you call it delayed onset fascia soreness rather than muscle soreness. Because most likely the location where free nerve endings are more sensitive to somebody pushing you or to movement is not in the muscle belly, it is in the fascial envelope. So at least for this condition, the research has shown very clearly fascia can be the origin of soft tissue pain. And the big assumption is that that may also be the case in many cases of low back pain. And now the big question, of course, is can we develop tests? Can we develop a differential protocol how to find out when fascia is the origin of the pain and when muscle is the origin of the pain, or the joint capsule, or some inflamed nerves, or the brain, or whatever. So that would be really nice to know. We don't have a clear, reliable test at this time, but we have some indications. So this was done here at the University of Heidelberg, where they injected hypotonic saline solution either into the erector spinae muscles and then checked where do the clients feel pain. And you can see it is more localized. When they injected the same amount of irritating substance into the fascial envelope of the back, they had a much broader area. So that already is an indication. If the client can point with their index finger to a particular area of their back and say that is where the origin of the pain is, then it is not so likely that the origin is in the fascia. Then it is more likely that it could be some muscular pain. That is already one vague indication that you have. Another one is if you listen to the description of the quality of the pain. In the muscular pain, when you give them a questionnaire, which qualities apply for your pain, they use very neutral, very clear description. So they say it's a cutting pain, a pain, or a stinging pain, etc. When you have fascial pain, they use the same descriptors, but in addition, they use quality descriptions which are from a different category. They say this is a cruel pain. This is a nasty pain. So you can hear this is not no longer a descriptive, there is an emotional association. So there is a part of the brain that goes into suffering. And you don't have that emotional association of a victimization and suffering as much in the muscular pain as you have it in fascia pain. So now we have already two indications. If the client usually deals with pain in a no pain, no gain attitude, I'm a man, I don't have pain, I'm born in Germany, or whatever nonsense they may have, and they have applied that to every kind of pain they had. But since they have this new kind of low back pain, you realize they had suddenly a character change. They are whining, they are sighing before they get down to the chair, and they are getting very much into a victimization. If that is not part of the personality that you have known from your husband before, uh, but if that is a new feature, then you have an increased likelihood if you associate also the regional spreading there. So if your husband cannot pinpoint where the area is, but if they use the whole palm to show where their low back pain is. So that is already some of the outcomes where we have learned how we can recognize fascial pain and separate it in some examples from a non-fascial pain. A very interesting area is the amount of emotional stress that may be involved in sensitizing the nervous system for the perception of soft tissue pain. And that is a model also from Heidelberg University by Professor Menze, where they did an experiment where they put rats into emotional stress. And they call that an elegant stress model. You may judge with me whether you call that elegant or not, because they were allowed to use that tiny amount of torture with the laboratory animals, and the ethics committee approved it because they said this is something that we do with our children every time they go into school, in which we ask them to sit still and not do whole body movement. So what they did is they took the rats into this plastic container where they could freely breathe, but they could not do yoga, get up, turn around. And they did that for 1 hour a day. So that's the same if you are now at home, and while I'm lecturing, you can get up from your chair and move around. Please do so. This is healthy. This is what children would be doing. But in school, they tell us to sit still because the person behind you also wants to see. So once a while, my wife takes me into an opera, and for 3 hours, I'm sitting there with her. And I would like to get up and move according to the music. But of course, she doesn't need to tell me. My inner voice tells me, Robert, don't do that. You are not here alone. And I could complain how much torture that is, but I think you would agree as an adult, you should be able to survive that amount of torture at least twice a year. So that's how often I may be willing to go into the opera. So that is the amount of torture that they did to these rats. And the question was, do you see any kind of brain damage, not in Robert after the opera, but in the rats after 1 hour of immobility in this plastic container? And first, they didn't see any kind of behavior change. Their eating was the same thing, their mating behavior and everything they looked at. But then they looked more closely, and they found at rest in the spinal cord, in the posterior horn of the spinal cord, where the sensory fibers are coming in, they found an increased activity. So it means the central nervous system is constantly fishing for information coming in, even if there is rest. So the activity at rest, the fishing for information activity was increased. And that was very interesting. Also, the area of stimulation. So if you stimulate a fascial tissue in the periphery, how many areas of the spinal cords are affected by it, that increased. So you have a higher tendency for for spreading of and for referred pain. And then they did 7 tests for nociception. How sensitive are these mildly tortured rats for electrical stimulation, for pinching, for cold stimulation, etc. And they found only 2 of them are increased in their sensitivity, and one is the pressure pain threshold. So if you push them at what amount of pressure, they behave as if this is painful, and they are much more sensitive to mild degrees of pressure than non-torture, non-emotionally stressed animals. And the other one is the wind-up phenomenon, which is repetitive stimulation. So if you do one stimulation one time and you compare it, how is the irritation if you do it in rapid succession 10 times? For most of us, if I tickle you one time and I tickle you 10 times, you would say 10 times is worse than one time. And then I estimate how much worse is it. Usually it's not 10 times worse, it's like twice as irritating as one time. And that is the wind-up phenomenon. And both of them are increased. Now, you could say this is animal behavior, but there is now a second study, also by a former mentee of Professor Menze, by Jonas Tessarts, and he has found a similar responsiveness in low back pain patients. So some of the low back pain patients, they had a history of childhood maltreatment 20 years before, 30 years before, if you ask them, in addition to the acute low back pain. And he used various questionnaires. Childhood maltreatment is post-traumatic stress disorder, one type, but it is one type of post-traumatic stress disorder where the questionnaires and where the assessment tools are highly developed because you have a lot of tools. And according to whether you include emotional childhood maltreatment, then you have more than 50% of the adults in our society affected, or whether you use the more restrictive term, 18% of sexual maltreatment, then you have a lower number. But they found that those clients who have low back pain, and in addition, who had post-traumatic stress disorder many decades before in their childhood, that exactly the same kind of sensitivity changes were observable. So if you did the 7 nociceptive tests that they had done with the rats before, only those 2 showed an increased sensitivity, which is the pressure pain threshold is much lower, not only in the area of the pelvis or of the lower back, but all over the body. The nervous system is no longer able to tolerate that much pain and stimulation that you have there. And also the repetitive stimulation is much, much worse in terms of enhancing effects that you cannot tolerate. And that is, of course, a very challenging stimulation for those of us who work as body workers with clients. So in addition to the soft tissue pain that in some of them may come from fascial tissues, you would also need to consider how primed is the central nervous system based on prior post-traumatic stress disorders in their life. And if they had post-traumatic stress disorder early in their life, then the pressure pain threshold is more sensitive, but it would also mean that you may have to do longer pauses between your roughing strokes in order not to get into the wind-up phenomenon in which they feel an increased irritation because of the second stimulation being much more experienced as sensitive than before. And that resonates well with another stimulating research from the group around Lorimer Mosley, where they try to find out how important is the stiffness, objective stiffness in the lower back, myofascial stiffness, if you measure it with such an indentometer device. So you indent You press on the lower back on the right side and on the left side, and you measure the stiffness resistance in Newton. And the expectation is people with low back pain, particularly if you have one-sided low back pain and you say my right side is more painful, that in palpation you would also feel the right side then being more stiffer. And then you would have the common vicious circle, which we structural integrators, but also manual therapists and movement therapists feel very competent in dealing, where you have a vicious circle between increased emotional tension leading to muscular stiffness. The muscular stiffness irritates some pain that leads to nociception, and the nociception leads to more stiffness. And then you are in a vicious circle, and then you try to relax and you say, the stiffness is the problem. Let me make it softer. But this is the first systematic study in which they compared the painfulness and the objective stiffness. And they found out, very interesting, there is no relationship between the painful location on the lower back and the increase of stiffness there. But there is a very clear relationship to the perceived stiffness. So they also asked the client, please give me a guess how strong I'm pushing here with this artificial finger. And you are pushing with 3 kilograms, and you ask him how many kilograms is it on 1 square centimeters. And the low back pain patient, they overestimate it. So they are less accurate, and they overestimate the stiffness, so they are less clear there than the healthy control patients. But very interesting, when you ask them not for the absolute stiffness, in which they are less accurate, but for the relative stiffness. So if you do 2 pushes and you ask them, tell me which one is stronger, then the people with low back pain, they are more sensitive for relative changes. And that didn't make sense. Of course, if they are less sensitive for objective measurements, that would be easy to explain because the nervous system is focused on nociception, and then it doesn't have much attention span left for proprioception. We will be looking at that later. But how can you explain that the low back pain patients are less clear in objective stiffness detection, but they are more refined in relative detection? So they also try to have an explanation. And the best explanation, maybe you have a different one, is that the brain is in a protection mode. That you say this is a dangerous area here. And when you are in a protection mode, then both of these increased changed sensitivities make sense. Then it makes sense to overestimate the absolute degree, because that way you react a few times too much, but that's not dangerous. But you don't overlook a potential injury to your body. So you have a magnifying glass on a potential irritation. So you are augmented, but when it comes to relative differences, you are more fine. So that would be the explanation from them. So what do you do if you have a hypothesis? If you're a clinician, you look for applications where you can apply it to your clients. And those clients who don't respond, you find for an excuse why they are not doing it. They are resistant, they have emotional problems, they are in whatever protection with you. And then you example in your book all the wonderful stories where your hypothesis was true. This is fine for a clinician, but for a scientist, that is not sufficient. You need a controlled experiment in which you test your hypothesis. You don't make it a belief, you formulate it as a hypothesis. And you develop a protocol. If my hypothesis is true, what would be the outcome of an experiment that you do? So they devised an experiment in which they changed the protection mode of the brain only, not by any change in the local tissue of the lumbar fascia or erector spinae, but by making an acoustic stimulation. to the brain of a strange sound. So let me see if you can hear it here. So they were indenting. That would be nice to see some people in the audience, how you're shivering here. Let me do it again. I'm torturing you because my hair is sticking up.
Mine too.
Yeah. So in Germany, that would be not allowed to do with your clients, but in Australia, they love things like that, to come up with agonizing sounds. So they did the same kind of 3 Newton or 30 Newton stimulation, and they asked the client, please estimate the amount of pressure. And both the healthy patients and the low back pain patients, they were overestimating the amount of force when there was this threatening sound. But the low back pain patients, the difference was much, much bigger than in healthy clients. And then they did, of course, a second sound here. Let's see. So maybe that could be done better. Let me run it once. They try to do a sound of letting the air out, like a sound. So let me hear it again. And that also had a sound because it was putting the protection mode and the stimulation of, or the association of a threat to the brain, to the central nervous system, into the opposite direction. And they showed very clearly people who have low back pain, their experience of the stiffness in the lower back is very much influenced by what the brain associates in terms of, is this a dangerous area in my body or a dangerous intervention and context or not? And that explains the differences that you have there. So that means that in our experience of soft tissue pain, the central nervous system may, in many instances, have a much bigger influence than the stiffness that we have under our hands. Now, in my rolfing practice for over 30 years, I guess I have accompanied at least 1,000 patients to get rid of their low back pain while I gave them their rolfing sessions. And I had my arrogant explanation, yes, it is the melting touch of my elbow. We rolfers, we know what we do, and the pain comes from the stiffness, and you see the melting effect. That may be true, but based on that experiment that I showed you, I'm now considering whether it was not the softening of the erector spinae that made a difference, because in this experiment there was no softening difference objectively between the low back pain patients and the healthy ones, but it may have been the sound in my voice after 5 minutes of melting work with my elbow. So when I touched them before, I would say, yes, you feel it's more stiff here, and this is much softer. And then I work there with half closed eyes, and then I say, there we go. Can you, wow, this is very nice. And you can hear in my voice, even though I'm lecturing, that this is a much more sedative, calming voice. And maybe that made the difference and not the peripheral stimulation with my elbow. So that's now my question, whether how big the peripheral tissue melting work is in terms of the effect, and how big the multisensorial input to the brain from the outer context, including my voice, my breathing, my interactions with the client, is independent from the peripheral tissue stiffness. And there are now some studies, we are also doing them, where we look at that brain influence in terms of stretching effects, but also foam rolling effects. Many studies have shown in foam rolling, but also in stretching, you have an increase of range of motion, but the increase of range of motion is not because the tissue is less stiff. If you measure the stiffness with an intentometer or with ultrasound elastography. So now they think it may be due to the brain associating something as I can tolerate it or I'm not able to tolerate it. So in this newer study here, they had clients do 5 minutes of yin yoga stretching. And of course, they were more flexible afterwards in terms of hamstring flexibility. And then they had half of the clients just rest. The others, they would do the cold immersion test, which is standardized in physiology, where you put the hand of the other side of your body into cold water for up to 3 minutes or how long you can tolerate it. And then you measure the difference in pressure pain threshold at the thumb of the other arm before the cold immersion and after the cold immersion. And in people who are healthy, after 3 minutes of cold immersion, your pressure pain sensitivity is much, much more resilient all over the body after 3 minutes of cold water immersion. And that, of course, has not much to do with circulation in the left hand, if you measure the pressure pain sensitivity in the right hand, but with your brain activating some fibers which are able to modulate peripheral signaling that you had there. And what they found out actually is that after the clients did this cold water immersion, they had again the same degree of range of motion improvement. So that makes us and the authors speculate that the range of motion improvement that you have after 5 minutes of yin yoga stretching, but also after foam rolling, we showed that in a study that we haven't published yet, that may be due to this conditioned pain modulation of the central nervous system. Because when you measure passive range of motion flexibility, the question is how far can you go? And you go as far until the nervous system says, this is dangerous now, I must protect myself. And after you have activated these descending fibers coming from the periaqueductal gray area in the cortex, then you are able to say, no, I can go 1 millimeter further. And that's what you do after a good yoga practice. That's what you do after you go on a foam roller. Don't, you start, of course, with a soft foam roller, but then you go to a medium stiff foam roller in which in the first second you say, no way. And then you say, oh, I can tolerate that a little bit more. I can even relax into the brain. And then you can measure with the cold immersion test how strong these descending pain fibers are, which is the difference in pressure pain threshold before cold water immersion and after cold water immersion that you have in this test. And I'm doing that now. I took this picture this morning. I told Melanie, this is the English garden. We had snow for the first time here. And I, in my bathers, but I had some neoprene gloves, I was swimming here for almost 1 kilometer for about 10 minutes. And I don't recommend it unless you are adapting your body to it. But it's very amazing to see what it does, probably to your immune system. I sleep better than any of the nights before. So this is what I can do here in the Corona period in Munich, particularly in the snow. So I do the Norwegian or the Wim Hof inspired cold water swimming, active swimming. But actually, I haven't done any study yet, not a control study. I'm more flexible in stretching afterwards, even hours later. So I'm quite convinced that cold water swimming, if you do it the right amount, don't do it unless you're prepared for it, may activate the same descending pain fibers that this study has been showing here that you are activating when doing yin yoga stretches. I'm not saying this is all there is to yin yoga, please not, but that is one explanation for some of the range of motion increases that you have after static stretching. So that would mean that the central nervous system tends to be much more involved than the regional stiffness increase in the local tissue. Then you could argue, why treat myofascial stiffness trigger points if you can just sing a hummingbird song to the client and say, yes, there we go, everything is fine, or throw them into the ice creek and ask them to swim. So you treat the brain and you don't treat the painful lower back. It seems to be, according to the research I have seen, the case in low back pain, that in low back pain, the regional stiffness seems to be secondary in terms of the magnitude of the influence, and the central nervous system effects, those that I have described, seem to be overriding. But I looked in the literature and I found one small study in which in the neck there is an association for our favorite vicious circle hypothesis, in which an increased muscle contraction leads to muscle stiffness increase, and that leads to pain, and the pain leads to more stiffness. So they found in people who have one-sided neck pain that there, if you use the stiffness measuring device that they have used in the Lorimer-Mosley study, there is an increased stiffness in the area of the neck that has the pain. You don't see that in the literature with low back pain. You often find exactly the opposite in low back pain. If people have low back pain on the right side, often the multifidus is softer and not stiffer on that side. But in the neck, it seems to be that way, so that a local stiffness increase is actually happening at the location and at the side of the body in which you have the pain. And then it makes sense to look at myofascial treatments, not only to stimulate the brain, but to melt the local stiffness that you had there. And then we can discuss how strong do you need to do it, is pressure or shearing force better, etc. And there is one small study, but I think it's very elegant, in which they use the duo ball from Black Roll, which is a two-balled foam roller, and used it with people who were tortured to sit on their desk for 4.5 hours. I think the ethics committee should prohibit studies in which people sit for 4.5 hours on their desk, but they allowed it because that's what you have all over town. So it was very easy for them to get ethics approval, to find some college students who are sitting on their desk for 4.5 hours and only go to pee, but they don't do real active breaks in between. And what they found is after 4.5 hours, the lower back is stiffer. Nobody had measured that before, and I want to understand, why is it stiffer? Is there an increased electrical muscle tonus? Is there a lack of water? Is the skin stiffer? Is there additional collagen? Probably not. Is there hyaluronan changed? So we don't know, but we know after long hours of sitting, your lower back is stiffer. They use this Indento Pro that we developed with them together, where you have a digital finger penetrating or indenting into the tissue, and you measure the resistance. And they did that at about 5 millimeters indentation, and they found out, yes, you have increased stiffness after 4.5 hours of sitting. And then they tried, can you lower the stiffness by 6 minutes of foam rolling on the wall. And I love that very much because it simulates the bear massage that we got from Ida Rolf, where the client uses your elbow in a similar way how a bear uses the resistance of a tree that they use to self-massage their lower back if they have some irritation or pain in their lower back. So that was the instruction that they gave to them. And they clearly showed that 6 minutes of an active roller massage decreases the stiffness that you have after 4.5 hours of sitting. That was all they did. But that's an elegant study, because now you can say everybody knows many hours of sitting is negative for the body, for the health on many levels. But that health degree seems to be associated with increased myofascial stiffness in the lower back And at least that aspect, that detrimental aspect, can be significantly improved by 6 minutes of foam roller massage. And they compared that with people not having a foam roller massage, but just standing at the coffee bar for 6 minutes. So that very small study, I think it's very elegant, because you can put that study and go to a company and say, I know how to fight the health problems associated with long-term sitting. I will instruct you, I will put a foam roller on a bar on the wall, and each client has to do this treatment. Otherwise, the coffee doesn't come out, or the computer doesn't start, or whatever you have there. So that would be a very nice treatment, not for the brain, according to that study, not, but for the local tissue stiffness. You see a little contradiction in me, because they did it with the lower back. And before I said in the lower back, the stiffness increase seems to be not so much involved in low back pain. So it would be even better to do it at the neck, but that's not what they have done. And also, that critique is partially negatable, because they didn't have low back pain as an issue. They only had increased stiffness, not low back pain, after long-term sitting here. But I like this study very much, because it also shows, besides the brain, the local stiffness is an issue, or can be a stiffness, or can be an issue, for which mechanical stimulation that we provide can be a good influence. Now let me come to the main subject that has been fascinating our department here in the last few months, which is the sympathetic innervation of fascia from the autonomic nervous system. And that is the latest publication from Siegfried Menze from Heidelberg University, where he did a calculation of all the different nerve endings in fascia. He mostly examined the thoracolumbar fascia. And he came to the conclusion that the sympathetic nerve endings are by far the most numerous compared with all other individual nerve endings. They make up almost 50%, 40% of the entire fascia innervation. So they are much more numerous than the myelinated, or than the nociceptive C fibers, or any kind of other known sensory innervation fibers that are found in fascia. And then the question is, what is the sympathetic nervous system doing in fascia if it is the most numerous innervation? A lot of them are surrounding a lumen, and that means they are mostly associated with vasoconstriction of a blood vessel. So you see that here, but you also see it in this beautiful picture that I got from Professor Neuhuber in red here. So that means a big function of the sympathetic nervous system, and I'm exploring that in my ice water swimming this morning, is vasoconstriction. That is a big push to your autonomic nervous system to say, get alive in my fingertips, in my toes, etc. And that is very, very rich, how numerous, how much sensory nerve endings the body invests in locally controlling blood or microcirculation. So that would be the main function. The microcirculation in the ground substance is regulated by the sympathetic nervous system, and that is the main function. In addition, there are some sympathetic nerve fibers shown here on the double arrows on the picture from Neuhuber, which are not associated with blood vessels. So they have an unknown function. And that is now the million-dollar question. Carlos Stecco is busy researching it. Heidelberg is researching it. I invite you to research it as well. What additional function does this rich sympathetic nervous system innervation in fascia have apart from microcirculation function? And the speculation from Professor Neuhuber and others is that it seems to have a trophic function, trophic with pH. So it changes the biochemistry, the nutrients, the biochemical composition in the local neighborhood of that tissue. And that is an interesting model, because if you look at which soft tissues have a higher sympathetic innervation, then I highly recommend this new book that is common in the acupuncture circles, but not yet in massage circles. It is a very nice model how some of the acupuncture meridians correspond with certain regional spinal innervation zones, but not only in a horizontal manner, but also from which branch. So she has been able to associate, for example, the area here in red is innervated by the bladder meridian, and you can see that is innervated by a dorsal ramus coming off of the central ramus, coming here from the central nervous system by the spinal cord. And she shows very clearly in the body, it is not sufficient to learn from which area, whether it's innervated from L2 or L4. You need to learn whether it's innervated from the dorsal ramus or from the ventral ramus or from this lateral branch. Because if it is innervated from the dorsal ramus, it has more than twice as much sympathetic innervation than the other tissues have. And that is now one of the critiques on Professor Menz's calculation of 40%, because he was basing that mostly on the thoracolumbar fascia. So it may be less if you study the fascial innervation in the fascia cruris, for example. But in this book, Dr. Vankua Kampik, she says this is why the soft connective tissue in the red area have a more emotional component. So if you remember, I don't play it anymore, this agonizing sound in which some of you had your hair sticking up, I imagine you have something that sticks up your hair out of fright, or you're crossing with your car a crossing, and somebody takes your right just in front of you, and you go, holy cow, I could have been killed that way. So when that happens, I have my hair sticking up, I have shivers, but I don't have the shivers in my navel, I don't have the shiver in my neck, I have them from the galea aponeurotica, nuchal fascia, down to the coccyx. So that is her convincing example, anecdotal example, why these soft connective tissue have a higher sympathetic innervation and therefore a higher sympathetic influence from the autonomic nervous system than myofascial tissues in other regions of the body. One of the gurus who has shaped my life very much was a phlebologist, Professor Staubesan. And in the late 90s, he published an article which electrified me, but also many other people, because he also found a rich density of sympathetic nerve endings in the fascia cruris, which is what he studies as a phlebologist. But in addition, he found contractile muscle cells, which he believed were smooth muscle cells. At least they had smooth muscle cell-like features. And he came up with the hypothesis, if you have smooth muscle cells in dense fascia and you have a rich sympathetic innervation, they could be related in the same way as other smooth muscles are controlled not by the somatic nervous system, like the arterioles or the viscera, but by the autonomic nervous system. So he came up with a theory in the same way how your musculoskeletal system can increase muscle tonus in split second, influenced by the somatic nervous system with the alpha motor tonus regulation, that in addition you have a fascial tonus regulation, which is influenced by the autonomic nervous system. And that would be more slow working, but it would be more long lasting, because a skeletal muscle will sooner or later tire and be exhausted if it is in an extreme tension, but a smooth muscle can hold the tension for many hours and many days without exhausting. And I felt that was a very stimulating hypothesis, and it fit to my experience as a Rolfing practitioner. In acute tension, it was oft muscle tonus, and with a good Feldenkrais treatment, you can relax them. But if people have chronic stress for several weeks, I could feel there is more a fascial stiffness separate to them. At that time, in the late 90s, we didn't have tools to measure the difference between fascial stiffness and muscular stiffness. Now we have the indentometer, in which we indent the skin and we realize at what depths do we have a stiffness increase on the painful side. Is it already 3 millimeters under the skin? Then it is more likely the fascia. Or is it only when I go inside the muscle belly and then the stiffness increases there? But in my experience, that made a lot of sense. With people with chronic emotional stress, I had more fascial stiffness. And he inspired me to examine his hypothesis. I did a lot of fascia histology sections. I looked for the smooth muscle cells. I did not really find them, but I found smooth muscle-like cells, which are called myofibroblasts. So they are connective tissue cells, but they have smooth muscle-like contractile features, which are these green-colored um, um, alpha, smooth muscle actin stress fiber bundles here. And that's a feature of smooth muscle cells, but also of the myofibroblasts. And we found them in all fascial tissues, not only in fascial tissues where we had known them before, where you have a pathology, like in frozen shoulder or in Dupuytren contracture, but we also found it in healthy fascia. But we found it more numerous in the human lumbar fascia, more numerous than in rat lumbar fascia or in other fascia from the human body that we had examined. So we even found one example where the density of the myofibroblast in the lumbar fascia in humans had the same density as you have in frozen shoulder. So we came up with this hypothesis that some cases of low back pain could possibly be called frozen lumbars, in which the stiffness and the cause of the pain in these people is associated not to muscular contraction, that is not the case in frozen shoulder, and also most likely not in these clients, but in a stiffness increase in the fascia that you have there due to a proliferation of these myofibroblasts. And we showed you can take samples of fascia and make them contract in an organ bars when stimulating them with the right chemical agents, but they do so very slowly. But we showed the magnitude of contraction is dependent on the density of these myofibroblasts. So there seems to be a causal relationship. So if you have a lot of myofibroblasts, the connective tissue contracts much stronger, but the contractions are very slow. So here in the superfusion, you shower them with a chemical substance. The water is then washes the substance off, nothing happens, and then half an hour later, the tissue contracts. Half an hour after the substance is gone, and then it takes another hour to relax. So it's a very slow response that you have there. But when you calculate if all the myofibroblasts that are able to stabilize, let's say L2 here, this is a cross section through the lumbar spine, and we calculated the maximum number of fascial tissues and of possible myofibroblasts in all muscle tissues that are able to stabilize the lumbar spine regionally here. So erector spinae with the fascial envelope, but also with the intramuscular connective tissue. Then you calculate what is the cross-sectional area, and we use the maximal force that we had in our organ bars, and you come up with 1 Newton, which is not very much. 1 Newton is a piece of chocolate. And if you translate that to your lower arm, then in a matter of 10 minutes, you can lift your index finger maybe 2 millimeters, which is not very impressive. So we showed, yes, fascia can contract, the contraction is slow. The contraction is dependent on the amount of myofibroblast, but we had to frustrate our friends from the martial art community who were hoping that we could explain how some martial artists are expressing superhuman power even though they don't have very big muscles. And if the muscles cannot explain their superhuman force, they thought it must be fascia. That is not a thought that a scientist would have. He would say it could be fascia, but of course, for a clinician, if it's not muscles, it must be fascia. And they said, Robert, when have you done your calculations? I want to publish that. That Bruce Lee, when he did his 1-inch punch, he did it from the fascia. I loved it. However, after 4 years of measurement and calculations, we had to tell them, no, it's not his fascia. That explains, at least not in a 10-minute interval, how he can have that much force, because he could only lift his finger a few millimeters. And in a fight, that would be not enough. But so we know in a short time frame, fascia can contract, but only in a ridiculously small amount of force. But if you give it more time, and I think Andrzej Pilat has also shown this beautiful video here of a fibroblast traveling. Anybody who wants to use that film here, you can get it from Peter Friedel's original publication, and therefore a small amount of charge. You can download it here. I don't have the video because I don't trust it in Zoom here, but you can see this cell starts on the upper right, and in about an hour, it travels to the lower left. And while doing so, it densifies the collagen matrix here in green. And if you imagine several cells doing that for the next few hours and days, you would expect the collagen matrix becoming more dense, not only by cellular contraction as part of the migration process, but also by what is called tissue contracture that includes matrix remodeling. So the cell, by contraction, puts collagen fibers together, and then it creates a glue to keep the collagen fibers together when it continues traveling. So contracture is based on tissue contraction, but it has additional tissue remodeling processes. And if you then look at tissue contracture, then actually fascial stiffness can create a lot of adhesions and stiffening as you have in frozen shoulder. So we have shown fascia can contract. It can even show contract very strongly if you give it several weeks time, several days time. But we had not succeeded in showing a relationship to the sympathetic nervous system, because all the substances that we got fascia to contract, they were cytokines associated with inflammation, with wound healing, like thromboxane, but none of the transmitters of the autonomic nervous system, like adrenaline, epinephrine, acetylcholine. I wanted them to contract, but these damn tissues didn't respond. And that's something I learned being a clinician. As a clinician and in many areas of life, self-fulfilling prophecies have a lot of power. If you really believe from the bottom of your heart into a principle, it will become true. And it will happen in your clients. It will also happen in your teaching. The less doubts you have, the more convincing you are. I tried that principle. I had learned it from Maharishi Mahesh Yogi, from Master Bhagwan and other masters. I tried it in the laboratory, but it didn't work. I wanted these organ bars to contract because I had a beautiful theory that the sympathetic nervous system can do fascial stiffness. But these damn organ bars, these fibroblasts, haven't learned the lesson about self-fulfilling prophecies. At least if you do sober scientific research, you look at the measurements with an unbiased view, and you realize, shit, the numbers are not confirming my hypothesis. There is no stiffness change after adrenaline stimulation and all the other substances that we have. So we gave up. We knew fascia can contract. It can contract strongly in a long time period, but the contracture seems to be more associated with inflammation and with wound healing. But then, after we had given up our hypothesis, we came about a new improvement in the area of psychoneuroimmunology, where they had found a missing link between sympathetic activation and certain T3 cells as part of the immune system in the lymph nodes. They knew for a long time that there is a relation. So when you are under acute sympathetic stress, you have different T3 cells expressed. They knew that, there was no doubt about it, but they didn't know the missing transmitter link for many years. And when they finally found it, this missing link, it was a big surprise for many because it is a well-known substance that nobody had associated with the sympathetic nervous system, at least not many people, which is TGF-beta 1, transforming growth factor. And we also had that in our battery in the organ bars. And it had been the one substance where the tissue reacted the slowest but the strongest altogether. So this was a very nice shift after we had given up the hope of our original hypothesis. It came back, and now we have a clear relationship that chronic sympathetic activation can lead to an altered expression as TGF-beta, and TGF-beta is the most potent chemical cytokine in your body, at least to our knowledge, that can regulate fascial stiffness that you have there. And then we are, of course, looking how, in addition to the sympathetic nervous system, could be the acidity. And that's often coming when people, from a nutritional perspective, are looking at fascial perspective. How could the acidity in the connective tissue, in the ground substance, influence the fascial stiffness? And in the past, I was not so sure, because the only experiment that existed was in the same technology that we had worked in the organ bars. And this is my master, Ian Naylor. He taught me how to work with organ bars. He's one of the world's best pharmacologists. But he knows, and I know, the fibroblasts in an organ bars behave very different to a human body in the alive body. But nevertheless, he had shown if you get fascial tissues to contract in an organ bars, they contract stronger in an acidic pH milieu in the substance. But we were both not sure whether we can translate that for the common question: if you have a less acidic pH in your ground substance because of eating less sugars and moving more healthily in terms of your daily movements, you can shift the pH, of course, in your ground substance, whether that has an influence. But now there is a second study with humans, with alive humans, not yet with healthy humans, but with humans who have lung fibrosis. And there they showed that lung fibrosis, of course, is dependent on TGF-beta, like many fibrotic diseases. But in addition, the lactic acid has an additive effect. And they showed this is independent of the TGF-beta. So if you increase the acidity, then the fibrosis, the stiffness of the bronchial connective tissue is worse. So now both experiments together make it more likely that both Ian Naylor and I are more convinced, not yet absolutely sure, if you find an intervention like meditation, daily movement, running or whatever, or more healthy nutrition, which changes the acidity in your ground substance into a more neutral level from an acidic level, that would also influence fascial stiffness. So this was very nice for us. We published it a year ago after 10 years of research. And I was very proud to publish it in Frontiers of Physiology, which is a high-ranking journal. We could have published it 3 or 4 years before, but we had the ambition to publish it in a high-ranking journal. And that takes, again, more years. They wanted us to do additional experiments. They didn't trust us. But finally, it was published, and that was a big moment for us. And it was generally very well treated and respected within the scientific community. Sadly for me, Professor Staubesand was no longer alive because basically we showed that his original hypothesis that there is a stiffness regulation in the fascial tissues, which seems to be driven from the autonomic nervous system, and that runs parallel and separate from the muscle tonus regulation, that seems to be true. And that reminded me of an interview that I had done in 2004 in the Journal of Bodywork and Movement Therapies. I think it was my very first article that I did there. And I interviewed Professor Staubesand by phone. And there he had this wonderful quote where he said, if you find any tonus change in fascia, think about the condition of the autonomic nervous system. But also, any intervention you are doing on the fascia may also be an intervention on the autonomic nervous system. And he suggested, and that's now the next piece of my lecture here, that we work with some of the sensory nerve endings in fascia that have a relationship. So when we stimulate fascial tissues with a rolling elbow, but maybe with a yin yoga stretch, some of them may have a connection to the autonomic nervous system. And of particular interest are the Ruffini endings. Many years ago, I had divided the sensory nerve endings associated with proprioception in fascia into 4 different categories: the 3 Italian brothers and the 3 nerve endings here. And each of them have a different personality or character. And this one is what I'm most attracted in my Rolfing melting strokes, the Ruffini endings. They are characterized, in my interpretation, more like by an old-fashioned beekeeper or psychoanalyst. They like to talk slow and go in circles and approach an issue from different angles. Now, if you go in the literature, you find that, and I find that very unique, that the Ruffini corpuscles are sensitive to different angles of stimulation. For example, if you pull, let's say, with 3 newtons here on this arrow and on this arrow, it may not stimulate the Ruffini endings. But if you stimulate the same amplitude in a different angle on the forward left and on the backwards right, it is sensitive. So it means the magnitude may not be so important as the angle of stimulation. And that reminds many of us to the local listening teaching dogma in osteopathy and in Rolfing practice, in which, of course, when we touch the client, we pay attention, are we at the right location? We also pay attention how much pressure is the right amount of pressure. But the most important question is not how much and where. If you work with Ruffini endings, it is at what angle does the tissue want to go? Of course, the tissue doesn't want anything, but it has a sensitive window in terms of the angle. So in this direction, it does not respond. In this direction, it does respond because it has that angular sensitivity. And very interesting, if you go in the literature, you see if you manage to stimulate the Ruffini endings, you get, in addition to a local tissue response that you would also get with Pacini receptors and with Golgi receptors, you get an autonomic response. And the autonomic response is a long-lasting vagal activation and also an inhibition of the sympathetic nervous system. And that makes it very unique to work with the Ruffini endings as part of the proprioceptive nervous system. I have been very lucky to get to know Ian Waterman. He is the most famous client in the whole area of proprioception research. Thanks to my friend Franz Mexner, he introduced me to Ian Waterman when he was examined for 4 days at the Max Planck Institute. Ian Waterman, you find him in the literature, he had a very unique immune system overreaction in which his immune system killed all myelinated sensory nerves below his neck. So he doesn't have any muscle spindles there. He doesn't have any rufinis, no paccinis, but he has free nerve endings for pain and for temperature, etc. And I like him very much because he expresses through a magnifying glass what your client has when the client has low back pain. And if you see the way how Ian Waterman walks, he's the only person who can walk with that proprioceptive deficiency. It is a little bit clumsy and it may remind you of some of your clients. And if you compare it, let's see if I can make it, to some women in Western Africa that my friend Achotson examined, and they seem to express a much higher proprioceptive refinement, particularly in their lumbar-dorsal fascia, in which they have a very unique rotatory and sagittal component that he doesn't have there. And they have a much higher economic efficiency in walking that has been shown in many of the studies. And that makes us think that the proprioception is a big part of everyday locomotion. And how elegant we move may depend on the sensitivity of the Ruffini endings and other endings in our whole body. And there is something new now. In the last few months, they discovered, no, actually before, they discovered a new piezo receptor, which is not a sensory nerve endings. It is a receptor in the membrane regulating the cellular sensitivity of muscle spindles and of Golgi tendon organs, and most likely also of Ruffini and Pacini's, but that has not been shown. But they found these highly mechanosensitive receptors in the cell membrane of muscle spindles and of Golgi tendon organs. And this was a big discovery because they showed that this is most likely where mechanosensation happens. And they found that there is a specific gene that's regulating how that piezo2 receptor is activated. And they found two young American ladies who are missing that gene, or they have a dysfunction there. And both of them, they have diminished proprioception. So that is a little experiment that we can do. If you have your left index finger here in front of you, and with open eyes, you go with your right index finger from your nose to the left finger, and you can do that very well. And then you do that with closed eyes 10 times as rapidly as you can do it. And the question is, what is the maximal deviation when you do it quickly with closed eyes? So for me, if I demonstrate it here, I do it very quickly. It may be 1 or 2 centimeters. So sometimes I was on the right side, sometimes on the left, but I wouldn't go 10 centimeters to the right or to the left. But in these two ladies, they are sisters, they would go to their ear. They would go to their eye, but they would not hit their nose, and they would also miss the object in front by several inches. So that would be similar like Ian Waterman, that they have diminished proprioception. Interesting, when they ask them about their childhood motor learning, it took them 6 years to learn biped. And that is almost as long as it took Ian Waterman as an adult. It took him 4 years to learn walking biped. So you see that walking biped is a master act in terms of proprioception. Now, the interesting thing that influenced me a lot in working with scoliotic clients is they found, before they showed a lot of the scoliotic girls that have idiopathic adolescent scoliosis, which is the majority, a lot of them have proprioceptive dysfunction with closed eyes. Not all of them, but the majority of them. So if a scoliotic girl closes her eyes and she has to do repetition mistake or do any proprioceptive refinement task, the difference between closed eyes and open eyes is bigger in a scoliotic girl than in a healthy girl. And but now they found out in those proprioceptively impaired scoliotic patients, many of them have this piezo2 dysfunction. And if you look at them, their muscle spindles are much smaller than the big spindles that you have in healthy controls. And that is now a new finding. So it means that the diminishment that they have in proprioception, which is contributing to them spending more time over one sit bone when they sit, because they don't even, they are not able to feel whether they are in symmetry or not. That could be one contributing factor in their growth period. That their diminished proprioception is most likely associated with a diminished expression and functioning of the muscle spindle. So that's not a small difference. This is not 10% less volume. This is a fraction of the volume and of the amount of intrafusal muscle fibers that you have there. So that makes me, so if you can detect a scoliosis early on, I would go into stimulating muscle spindles with vibratory stimulation. I don't know whether I can make them bigger, whether I can make them sprout. I don't know if that's possible in puberty. In childhood, it may be possible. But at least I have a chance to stimulate the processing. So if I have less intrafusal muscle fibers here in the spindle for being associated with proprioception, then I want the central nervous system to be more refined in detecting their stimulation. The muscle spindles are interesting because they are embedded into the perimuseum. And the perimuseum, that has been shown by the more recent research by Peter Heying and others, seems to be the place where fascial fibrosis starts before it spreads into the epimuseum and other areas. So that has been shown by Peter Heying and others in spastic children with cerebral palsy. Of course, their myofascial tissue often is stiffer in their calf, but the question is it the epimuseum around the muscle that you don't see here? Is it the endomuseum that's not changed in the spastic person down here? But it is certain portion of the perimuseum. That's where the stiffness and the fibrosis starts to happen. Now, if you have a stiffening of the perimuseum, then even if your muscle spindle is very rich, it will have very little stimulation. So you may have some people who have their piezo2 receptors, they have sufficient muscle spindles, they don't have any scoliosis, but their muscle spindles are protected from mechanical stimulation by a big, stiff protection shell of collagen fibers in the perimuseum. And then you may have the same problem that you have diminished proprioception there. Let me go here towards the even stimulating field of interoception, which is also body sensation, but not body sensation related with proprioception in terms of where is my body in space and in terms of biomechanical forces, but in terms of physiological needs. And these are free nerve endings. None of them is myelinated, that are associated with physiological functions, so with temperature regulation, for example, or with heartbeat, or with a thirst or air hunger, and with trembling, etc. And these are the most numerous of the free nerve endings here. And in a recent calculation, we came up with a proportion of 1 to 7. So if you compare the proprioceptive nerve endings that Ian Waterman is missing with the interoceptive nerve endings, it is much, much more nerve endings that are associated with physiological organ functioning. And they project very different to the brain. So on the left, you have the common pathways for the Golgi, for the muscle spindles. They go up here on the spinal cord via the pyramidal tract, and they project to the somatomotor area here, where you have kind of the body schema. whereas the free nerve endings in your viscera and other free nerve endings associated with interoception, they project to the insula, that is gray matter, that normally the gray matter of the cortex is on the outside, but in one area you have the outside folded inward, and that is the insula. And that is an area where physiological body stimulations are linked with your physiological needs. And one thing that the insula does is when there is stimulation in terms of temperatures, changes, or whatever, it always compares it, what is my physiological need? And then it says, this change is good or I don't like it. So there is always an affective component. And that is something unique for interoception. In proprioception, if I ask you which of your knees is more forward now or which shoulder is slightly higher, you can answer it. But if I ask you which knee is more happy than the other, you may have an answer or you may not have an answer. You can say this one is more forward, but is more forward good? You may say it's just different. But if I change the temperature in the bathtub to be 1 degree warmer or 1 degree lower, you can always say, I like it or I don't like it. So interoception always has an emotional association associated with it. And a big part of it is the so-called enteric brain, in which you have a very rich number of free nerve endings around your visceral connective tissue, and the connection to the central nervous system is actually very small that you have up there. And there has been a lot of research by Antonio Damasio and others that a healthy human person who is able to make reasonable, complex decisions in their life, they always have learned to use their gut feeling as so-called somatic markers. So when you make a complex decision, should you move to another city or not, you make all the rational calculations, but at the end you say, let me sleep over it. And then your gut feeling, and you learn during a lifetime how to differentiate whether you have eaten something wrong or whether you're afraid of something or whether it's butterflies. As a beginner, you cannot separate them. But the older, the wiser you get, the more you learn to trust your gut feelings here. And there are certain connections, they are stronger in Homo sapiens. That is very surprising. So as Homo sapiens, we should have a more reliable or bigger or immediate gut feeling for what is good to eat or what is good for our body and our life than other animals. I doubt that. If I observe myself what I eat and I compare myself with animals, I have my doubts. But in terms of anatomy, we have a direct highway that only Homo sapiens has, in which our insula has a more direct information about our gut feelings and other interoceptive stimulations. And if these red highways are disturbed by some kind of tumor, you can have an IQ of 150, but you are no longer able to make complex decisions in social life that include listening to your somatic markers. And very interesting, these red highways are associated with a sense of self in a physiological, in a philosophical sense. So after a good yin yoga lesson, you go home and you feel more whole. You don't say, I'm 20 robots fighting with itself. Of course, your EEG would show it. You know, your right hand doesn't, you say, I don't want to eat cookies anymore, and the left hand takes it without listening to you. So, of course, you are a mess. But after a yin yoga session or a good stretching session or another interest, you go home and you feel as if you are one organismic entity. And philosophers have been also, what is that sense of oneself? And that is disturbed in certain psychiatric pathologies, and it can be stronger on some days. In Corona, some days I wake up in the morning and I wonder myself whether I'm sleeping or whether I'm awake. And that is not a good condition. in terms of this feeling of self. So let me not go into the philosophy of that, but it's a very meaningful sense that people have. And that is less related to proprioception. It is more related to interoception that we have here. One part of interoception is the microcirculation that they had here. And in fibromyalgia, for many years, they were trying to find a morphological substrate, which is different, that the fascia is different in them. They found a minute increase in the endomuseum. It's slightly thicker in them, but the muscle fibers are not very different. The thing, so they didn't find a real reliable uh, conclusive difference in terms of the morphology. Then they looked for the free nerve endings in fibromyalgia patients and compared them with depressive patients and also with healthy patients. And I would have expected that they have less proprioceptive nerve endings and more nociceptive free nerve endings. But what they actually found is they have less nociceptive free nerve endings in their subcutaneous connective tissue, except for one type of free nerve endings, and that is related to the microcirculation around the so-called shunts. So you regulate your temperature by deciding how much water goes into the periphery and warms your fingers, and how much water you take a shortcut to go back to the heart without warming your fingertips. And that is a healthy regulation, and that's related with the sympathetic nervous system. And there are two types of free nerve endings. One is there to sense how much blood is going through these shunts, and the other is there to not sense, but to regulate the amount of water flow via these shortcuts. Both of these are 100 times magnified. So that is a very surprising finding. I like research when you find something that you did not expect the least. So yes, free nerve endings in them are paradoxically diminished, but one time is upregulated in a pathological manner that has to do with an attempt to improve your temperature regulation. And if you work with fibromyalgia patients, nobody claims to be able to heal them with one session. It's usually a long-term process that you have with them. And of course, they complain of pressure pain, they complain of movement pain, of fatigue. But when you listen to them a little longer, they also complain of temperature regulation. But that's not their first complaint, it's their secondary complaint. That when they have cold fingers or feet in the bed, it takes them longer if the room and the air, if the temperature in the room is too, so they cannot regulate their temperature as well as other people. So now people speculate whether fibromyalgia, in terms of the origin, not of the amount of suffering, but of the origin of the causal contribution, is primarily an interoceptive dysfunction in sensing and regulating your warmth in your body, how much you open your blood vessels into the periphery and how much you pull them back. And I've been working with them now with exercises, almost inspired by the anthroposophical teaching or by autogenic training, where you warm your fingertips just by thinking of connecting into the room. If you want to have warmer fingers, I did that this morning when swimming in the ice creek. How can I warm my fingertips? I can do skeletal movements like mad, but that doesn't work very well. I think that they are very warm and that I want to touch a cold bird and want to make it warmer. So this is more like an energetic regulation, how I open my energetic, here I'm talking as a scientist with words I should never use, but so in terms of my imagination, I open my peripheral endings towards the environment. And I found that quite beneficial also in working with fibromyalgia patients. So we haven't studied that, but that is a very nice unexpected dimension of working with interoception. Here, towards the end, many of you know that the tactile C fibers have been discovered more than 10 years ago with Scandinavian researchers, not in Ian Waterman, but in the Scandinavian woman who has the same pathology. They found you can touch her, and she cannot tell where you touched her, but she can always tell that she is touched. With you and me, that would be different. But she doesn't have proprioception, would be the same with Ian Waterman, but she has free nerve endings in the skin and in the superficial fascia under the skin that they discovered subsequently that project only to the insula, not to the somatomotor cortex. That means you don't have a body schema to say this is my right shoulder. But your insula says, I'm socially connected. And they found that we have that wherever we have hairy skin, which is almost everywhere in Homo sapiens, except on our lips, on our fingertips, and on the palms, on the bottom of our feet. And they are related with grooming as a social affiliation and of a manner to regulate stress coping in groups. And they found this is very, very important. Pavians spend about 6 hours per week to groom each other. They found with humans it needs to be a certain speed. It can be 1 centimeter per second up to 3. 3 is ideal according to a recent study, but it should not be more than 10 centimeters per second stroking. And only if you made eye contact and zoom in, no, yes, the weather is bad, you have a nice shirt, etc. So you need to make a human connection that the client feels, yes, Robert is not threatening and he's socially on my side. And then you stroke them and you can see that the insula is getting into a very different state in which your immune system is more healthy, your wound healing is healthy, etc. So that has been having a big influence on massage and manual therapy. They now train massage therapists to basically administer their touch for the insula, not for touching, and not for stimulating proprioception. And in my classes, I've been teaching what Moshe Feldenkrais called the mother care technique. So where you slowly pinch and pull on the fascia nuchae here. And if you do that slowly in a protected environment and you mumble a little so that the client feels it's half boring what Robert is doing, then after about 3 minutes, you can see their belly breathing change. And I'm pretty convinced that has to do with these tactile C fibers that they discovered there. And then the question is, where is that more important than proprioceptive stimulation? For proprioceptive stimulation, we know that low back pain, proprioception is diminished, but also complex regional pain syndrome and several other pathologies like scoliosis. For interoception, very interesting, post-traumatic stress disorder. In post-traumatic stress disorder, it would be almost a waste of time to do Feldenkrais or Iyengar yoga with them, in which you try to improve their proprioception primarily, because the dysfunction seems to be associated with interoception. So from my superficial background in many of these movement and manual therapies, I put in some of them that I'm familiar with. In Iyengar, of course, not the advanced lessons, but more the basic lessons. They are very proprioceptively precise, and they would be ideal if you have somebody with low back pain, but they would be less ideal if you have somebody with post-traumatic stress disorder on your table. And then if you go to your competitor who hates science and who believes in chakras and does chanting in his session with sandalwood, that could be much more efficient, because that practitioner may ask the client, do you feel the energy streaming in your right leg? And just asking that question, whether the client is able to answer or not, is sensitizing the insula more, which then is probably more powerful than when a Feldenkrais teacher asks the client which shoulder blade has a more flat contact with the ground when you lie on your back. And let me go to this one here, that I finish on time. That recently they found also three nerve endings that project to the insula that are associated with pleasant deep touch. They found them by simulating the pressure we have, for example, in rolfing and structural integration, with a pressure cup, a cuff around the lower leg, in which you slowly build up the pressure, but to a magnitude where it's not threatening over 6 seconds. And then you let that go, and you do that in a slow, rhythmic manner. And you ask the client how they feel about it. And they often feel this as very calming. And the surprise is when you measure what happens in the insula, it seems to be identical with the superficial grooming on the skin. So you have about the same amount of areas in the insula affected as in the social touch that you have in the grooming there. So that is very interesting. When you have somebody in tears next to you because he lost an important person in his life or something like that, it may be nice if you do gentle stroking and you follow the Feldenkrais dogma: the softer, the gentler, the more powerful. But once a while, it may work good, in addition to gentle touching, that you give them a strong hug and you look at them and tell them, I'm on your side. And many of the clients feel that this combination of superficial grooming and a pleasant deep touch often is more powerful than only the gentle touching that you had before. Interesting enough, if you go in the literature, the area of the insula that are stimulated by the pleasant deep touch are more the middle and the anterior region, as opposed to the skin touch. And these areas are described in neurophysiology of having a more salient capacity. Salience is a weird word in neurophysiology. You could translate that as this is experienced as meaningful. It has a deeper meaning. So this is now a rapid area of research. For example, in some cases of autism spectrum disorder, they want a stronger pressure on certain days. Also with attention deficit hyperactivity disorder, if you give them a heavy coat, they can relax more in school, of course, only if they want it, not as a punishment. And we have the same thing sometimes if you have been giving somebody very superficial Feldenkrais, tactile stimulation on the skin. I'm not saying this is all there is to Feldenkrais, not, so let's say any kind of other superficial touching. And then you give them a slow, careful, deep rolfing touch that they feel like, wow, this has an added meaning, importance to my inner relaxation that you get there. So I'm sure there will be more research associated with that area. And very interesting, it makes a difference not only what you do, but how the client participates in what you do. And that has been a big discussion between Rolfers and Feldenkrais for many years. If you touch the client, should the client concentrate and be in the present moment with all his attention under your touching finger? Or is it fine if the client daydreams and is not in the here and now in your present touch? Moshe Feldenkrais, he advocates that in some of the treatments, it's even good if the client daydreams, because then he is more interacting with the subconscious participation of the brain rather than with the consciousness. And based on Milton Erickson, he said this can be 10 times more powerful, but he didn't have research. He only had anecdotes. Now we have a piece of research, and I like it very much, again by Lorimer Mosley. He did a proprioceptive stimulation treatment for people with complex regional pain syndrome, where the whole arm is affected. by dysfunctions, and he marked 5 points on the affected hand, and he was hiding the hand, and then the experimenter would touch one of the 5 spots, either with the sharp end of the pencil or with the rubber end, and ask the patient which of the 5 points that you don't see, but you have a photograph in front of you, but hopefully you feel them, am I touching, and with what kind of ending am I touching it? And that's your whole therapy for 10 minutes a day. And that is very cheap. It's nothing compared with a 50 or 100-minute dwarfing session, but it was very effective. Already after a few weeks, their proprioception was improved and their pain was much, much better. But then the question was, how important is the cortical participation of the client? And he didn't rely on anecdotes, as Moshe Feldenkrais did. He did a control group where he did exactly the same amount of spot stimulations. So the peripheral stimulation was exactly the same, but the cortical attention was not directed to the giving feedback about the location. They were able to read a book or to daydream or something like that. And then they compared. So if this took 5 weeks to improve, what is your expectation? How many weeks it took when you communicated with the subconsciousness and you allow the client to daydream in their cortical uh, uh, conscious attention? Interesting enough, there was not only a slower improvement, there was zero improvement. So that means if you have a myofascial pain syndrome, at least complex regional pain syndrome, but probably also other myofascial pain that goes along with diminished proprioception. Remember my slide? That includes complex regional pain syndrome, it includes low back pain, whiplash, etc., but it does not include fibromyalgia, it does not include post-traumatic stress disorder, etc. So if you have a client where proprioceptive dysfunction is involved, then if you allow them to daydream, nothing is happening, at least during those stimulations, because you need their conscious attention there. And I like that very much. And now the question is mindful attention, you could call it like that, seems to be an absolute requirement, not a fostering positive uh, um, parameter, but an absolute requirement for dysfunctions of the proprioceptive nervous system component. Um, but proprioception involves myelinated nerve fibers that can do a very rapid signaling. So if you ask a dancer which knee is more hyperextended, he can answer in a split second. And you could trust that they use their spindles and Golgi tendinomes for that. But if you ask the client, which of your feet do you feel more connected now? And they answer in a split second, then I know they haven't had the time to dive into it, because the free nerve endings are much slower. So it takes at least half a second or 1 second to go into the leg and compare the temperature in your right foot with your left foot. So I think mindful attention is a very interesting dimension. In another study that I have skipped over, we showed that mindful attention training can increase your palpatory acuity in testing. They did that with a group of osteopaths. So how sensitive your hands are can be influenced by mindfulness training that you do there. But also for the client, mindful attention is something that is positive for proprioception. And we speculate that the mindful attention for interoception takes more listening time. So when you ask the client, which leg are you feel more connected, which one feels more healthy, more energized, which leg do you feel more at home, embodiment, very important component of interoception. And if they answer like a dancer in a split second, you say, take a moment, go deeper, and then answer me again. So this is a very important aspect. I could talk for hours. I will not do so because I look forward to interaction. And I always finish, almost always, with the slogan of our Munich group that we have discovered to work for ourselves. And I can see this webinar series doing the same here, that if you want to understand connective tissue as a networking organ, it works very well if you become a good networker yourself. And that is something that has been working for us. So rather than competing with each other, I have a better technique than you are, and I don't share my slides with you because I want to be more famous than you are. We are doing like the people are doing in the early years of the gold diggers rush. The people are doing in chaos theories in the first years, and we are right there in connective tissue research. That's a big area, multidisciplinary activities from all ends. You don't have to push somebody away to make a good contribution. So a lot of people are collaborating now. And I hope it continues that way. And we are using that. So the more you can share with others, the more you can look through their perspective, the more you learn about fascia yourself. Thank you very much.